So let's talk about quite possibly one of the coolest muscular based injuries. I don't know. I think it's one of the coolest based muscular injuries, mainly because the surgery is so freaking gnarly, right? So, compartment syndrome usually is going to occur in the anterior compartment of the lower leg, of the shank, of the shin, however you want to talk about it. All going to be talking to the same thing. There's other areas of muscles that you can also get compartment syndrome. It's not just limited to the anterior compartment of the lower leg, but it's where it predominantly happens. It can be either an acute or a chronic condition. So you can have chronic levels of compartment syndrome. And you'll see this often. Often's a loose term. You'll see this in a lot of high distance runners, people that really put a lot of miles on their legs, that will start to develop more of a chronic situation of compartment syndrome that doesn't become incredibly like life altering, if you will. But you can also have an acute version of compartment syndrome. And the acute version of compartment syndrome usually comes or coincides with an acute trauma. So it could be a car wreck. It could be getting kicked incredibly hard in the shin. It could be a football tackle. It could be a soccer tackle. It could be over like a period of extreme overuse. So like going out and running 100 miles or something like that, which some people do, which is crazy, right? That can lead to an acute version of compartment syndrome. And sometimes, essentially, what compartment syndrome is it's a swelling of the muscle, and when that muscle actually swells too much or it starts to increase in size too much, they actually have to do something that's called a fasciotomy, which is they take and basically run a scalpel all the way down that shin in order to release the pressure on the muscle. And they literally go in and expose and cut through all the fascia and just let that muscle out so that it can actually not destroy itself. You'll see sometimes that there's necrosis that can occur with this and all, but like how gnarly of a surgery is that? Like imagine if that was your leg. That's crazy. I actually was playing soccer with a kid back in high school. I was fairly competitive, and he got kicked really hard in the anterior. It was tibialis anterior, which runs right along the shin bone. And he actually ended up getting compartment syndrome and had to have this surgery. And he was out for like a year. It was a crazy thing. Ever since then, I've always thought this was a really cool injury that can occur. I would hate to have it, but There's other common injuries that are going to be associated with the lower limbs. Shin splints, pretty much everyone's always had them. It's usually like a colloquially used term, so it's a frequently or commonly used term. People usually use it to apply to a series of issues or a like smattering of clinical pathologies, and that's not necessarily the truth, right? Like there's not really like a true diagnosis or a specific diagnosis associated with shin splints. You can have different issues that are musculotendinous, but it's not like you don't ever go in and be like, oh yeah, you got your official diagnosis is shin splints. It doesn't really happen. It can be stress fractures, it could be musculotendinous issues, it could be strains, it could be whatever. Dr. Jay Heel is a fantastic resource on this. He will hammer into you that not to ever use the term shin splints, but regardless, you'll hear this term used a lot. When you hear this term used a lot, you can know that it's associated with the lower limb, typically the anterior side of the lower shanker of the lower limb. When it comes to muscle groups, just like we've kind of taken the approach for everywhere else, we're going to take regional based muscle groups, or we're going to take action based muscle groups, right? So it could be anterior, posterior, lateral, medial. It could be plantar flexors, dorsiflexors, everter, inverter, whatever. This is going to be a list of your plantar flexors. I'm going to put together another spreadsheet just like the last one for the last test for you guys that will include the ankle as well. So this is where you'll see a lot of these motions. But in brief, you've got gastroc, a couple of flexors, the fibularis longus and brevis, plantaris, soleus, tibialis posterior, right? These are going to be the muscles that plantar flex, or they bring the toes down. If they're bringing the toes down, they're going to tend to actually be running along the posterior side of the lower leg, or the posterior side of the tib fib, and across the ankle. Now, our dorsiflexors are going to be responsible for raising our toes, and they're going to predominantly be on the anterior side. They can be lateral, medial, whatever, but they're really going to be on the anterior side. And because they're going to be pulling up on that toe. Similar to the hand and the wrist, we're going to have a rather than have a carpal tunnel, we're going to have the superior extensor retinaculum. Hate that word. I suck at words. You guys know this. What this is going to do is essentially strap in those dorsiflexors. So it's actually going to help hold in some of those dorsiflexors so that they're able to not bowstring or not basically overly tighten and draw straight across the leg. And if you look on this slide, you can actually see that retinaculum holding down those muscle fibers and actually holding them in place. We're going to have everters and inverters, just like we have dorsiflexors and plantar flexors. Everters, fibularis longus, fibularis brevis, fibularis tertius, and extensor digitorum longus. We're going to go over all these. But they're going to be running along the lateral side. Because remember, eversion, we're going to be rolling away. The sole's going to be moving towards the lateral side. So we're rolling out. So they're going to be on the lateral side as we constrict or contract from insertion towards origin. You're going to shorten and pull that muscle sideways. Inverters are going to be on the medial side. This is our TA, posterior tib. TA stands for tibialis anterior, flexor digitorum longus, as well as flexor hallucis longus. So let's talk the major muscles of the ankle. You've probably heard of the gastroc. Our gastroc is really going to be one of our predominant plantar flexors. The plantar flexors, the gastroc and the soleus, the predominant ones, are going to both kind of terminate in the Achilles tendon. So they're going to become and kind of merge into the Achilles tendon. The gastroc has two heads. It has a medial head and it has a lateral head that they originate on the posterior surfaces of the medial and lateral condyle of the femur. Because they're two joint muscles, because they span the knee and the ankle, they're going to be associated with both knee flexion and plantar flexion of the ankle. This is really that meaty calf muscle that you see on people. We're going to have a plantaris muscle. So the plantaris muscle is responsible for none other than plantar flexion. It's going to originate just above the lateral epicondyle of the femur, and it's going to insert all the way down on the medial surface of the calcaneus. So it's going to kind of strap across the width of the lower leg. Because it's crossing those two joints again, it's going to be associated with both knee flexion and plantar flexion. Our soleus is going to be another major plantar flexor. It's going to have a huge broad origin, so it's going to be able to exert quite a bit of force. And it's going to insert again into that Achilles tendon and into the posterior surface of the calcaneus. So when you rupture an Achilles, you actually have quite a bit of calf damage as well. And it's really going to be predominantly responsible or almost exclusively responsible for plantar flexion. And you can see that it doesn't cross the knee. It's all on tib fib, so it's only going to be ankle actions. The fibularis longus, again, we've already talked about this one, but it's going to be running behind those malleoli so that it's actually going to be using the malleoli as a pulley. It's going to be responsible for eversion of the foot, but it's also going to be responsible for plantar flexion. Because it's running around the back of the malleoli, it's running around the back of the ankle, it's actually going to be able to pull down on the ankle and produce a plantar flexion motion. Fibularis brevis, same concept here. Eversion of the foot because it's on the lateral surface of the fibula, but then it's also going to insert all the way on the bottom of the foot, on the fifth metatarsal, so on the metatarsal associated with the pinky toe, and it's going to be responsible for eversion and plantar flexion. Fibularis tertius is going to be responsible for eversion and dorsiflexion. So if it's dorsiflexion, that means we're going to be on the anterior side of things. We're actually going to be on the anterior side of the fibula, hence fibularis, and we're going to insert all the way down on the base of the pinky toe. So it's going to be responsible for dorsiflexion, actually pulling the toes up towards, or pulling the foot up towards the shin. Our extensor digitorum longus is going to originate on the lateral epicondyle of the tibia, all the way up here, as well as down the length of the fibula, pretty much most of the fibula. And it's going to insert all the way on the top, on the dorsal side, I see what I did there, of the distal phalanx and the 4 toes. So it's actually going to be responsible for crossing all the way down the ankle as well as across the foot. This is going to be just like our flexors and extensors of our hand, right? It's crossing multiple joints, so it's going to have action on multiple joints. So it's going to be responsible for extension at the 4 lesser toes. So every toe that's not the big toe, not the great toe, not hallucis, we're going to have an extension of. We're also going to be responsible for dorsiflexing that foot, pulling the foot up towards the shin. And because it's on the lateral side of the tibia and on the fibula, it's actually going to be responsible for some eversion. So as you contract, it'll actually roll the foot out some. Extensor hallucis longus, think extensor digitorum longus, but we're actually operating on the great toe, on the big toe, on the hallucis. Again, dorsiflexion of the foot. So dorsiflexion of the ankle and extension of the great toe. Our TA, this one is super common. You'll hear about the TA a lot. It's going to basically, you can actually feel it. If you dorsiflex and you dorsiflex hard, you'll actually feel your tibialis anterior contract. Now take and run your fingers along that muscle, and that is, you are palpating the TA. You're actually palpating the tibialis anterior. It's going to originate on pretty much the entire lateral surface of the tibia, on the anterior lateral surface of the tibia, and it's going to insert on the medial cuneiform bone. So all the way on the middle of that foot, middle of the forefoot, on that middle bone. So it's going to be responsible for dorsiflexion and inversion. Our posterior tibialis, or tibialis posterior, is actually going to have an origination that is going to be on the posterior surface of the interosseous membrane. So this membrane that runs between the tibia and the fibula is actually going to be where this the tibialis posterior is going to be originating, and it's going to wrap around the back of the foot, wrap around the back of the ankle, under the medial malleolus, and then it's going to insert on the bottom of the foot on those like the navicular cuneiform, as well as those kind of goofy metatarsal bones down in there. So it's going to have a pretty broad insertion. So it's going to be responsible for plantar flexing because it's wrapping around the back of the ankle and inserting on the bottom of the foot. Flexor digitorum longus, if we're talking about flexion of the toes, flexor digit, we're going to be wrapping around the back of the foot. We're going to be wrapping around the back of the ankle, under the medial malleolus here, and then actually inserting all the way on the base of the distal phalanx. So we're going to originate on the back of the tibia and insert after wrapping around the back of the ankle underneath the medial malleolus, and then insert all the way onto the distal 4 toes. And what that's going to do is it's going to be responsible for plantar flexing of the ankle, because it's actually going to be pulling that ankle down, but it's also going to be responsible for flexing those toes, or pulling those toes down. So as we kind of stabilize the ankle, we'll be able to pull those toes down. Flexor hallucis longus, just like we had flexor digitorum longus, flexor hallucis longus is going to be doing the same thing. We're just going to be operating on that big toe. So we're going to wrap around the medial side of that ankle, wrap around the back side of the medial malleolus, and we're going to insert all the way down on that great toe, on the bottom of that great toe. Here is where things get crazy, right? We're going to have all these intrinsic muscles of the foot. There's going to be a ton of them. They all are going to originate and insert within the foot. Realistically, I'm not going to want you to know all of these. I'm just not, right? It's very difficult to be able to palpate these, to be able to figure out the difference. And realistically, like it's almost impossible to be able to tell the difference between these. So don't worry too much about the intrinsic muscles of the foot. What I do want you to know is that there is dorsal intrinsic muscles of the foot, so they're going to be on the top side of the foot, and there's plantar muscles, right? So they're going to be on the bottom side of the foot. Just like we had in the hands, we're going to have lumbricals and all of that. again, it's really difficult. I'm not going to ask you guys to know too much about the intrinsic muscles of the foot. Just providing you guys some more information, just like we were talking about grouping by location for the ankle, those anterior, posterior, medial, and laterals. You can group those intrinsic muscles of the foot, medial, central, dorsal, right? It's just for referral information for you guys. Don't focus on this for the final. Don't focus on this for exam. So that's it. You made it through another pair of joints, and you're doing a great job.